a similar talk. I thought I would take my talk as a second talk, and I would be taking you on enhancements for regressions and the difference defines treatment. Essentially, we all need to know that regressions is a multifactorial in the sense you find regressions if you have a high refractive error. You could find regressions if there's a thin residual stromal bed, if you have used smaller optic zones, if you're treating higher astigmatism, if you're treating older age group patients, if there is a dry eye status which has not been detected, and also if there is a change in the axial length and there has been a myopic shift in these eyes, and also a latent hyperopia which gets unraveled and there are some lenticular shifts. The other aspects to be looked at in regression is the amount of epithelial hyperplasia and the remodeling that has occurred. The inflammatory cascade itself is known to trigger greater epithelial response. The altered reinnervation which occurs in these dry eye status can trigger regression. And the steeper gradients which are getting created by the high myopic corrections, high astigmatism, and hyperopic corrections are known to increase epithelial response. And the stromal biomechanical response is also to be noted, like in these thinned out corneas and the reduced tensile strength, because of which you see a forward protrusion of the posterior lamellae and an apparent myopic shift which presents. And that is why there is even a thought of temporarily treating these eyes with IOP lowering drugs, but we really do not know how effective it is. Regression is also seen in those earlier days of using those microkeratome meniscus flaps, and it is seen that it is seen more in meniscus flaps than against the planar architecture. The architecture itself is a factor for epithelial remodeling to be different, and surface ablations in high corrections. And in fact, we have seen in different studies that the rate of regression in LASIK versus SMILE is anything from 5 to 28%, compared to SMILE, which is about less than 2.9%. Having understood the different responses and the factors which trigger regression, what do? So we first need to do a slit lamp evaluation and look whether you are able to define the flap edge. Do you think the flap edge is very fibrous, which would tell us that it might be difficult to lift the flap? Does the flap look centered, which would tell us whether we are going to lift the flap again? A decentered flap we wouldn't lift. You would also like to look at the hinge. How does the hinge look? Is it low hinge? You would like to do the topography to see whether the corneal thickness is good, whether there is any pachymetric progression which is cluing you that it might be something more sinister. Is the surface regular? The asymmetric bow tie, inferior steepening, look at the Q value. And of course, an anterior and posterior floats, because constantly we can't presume regression if there is ectasia underlying. It makes sense to also look at the pupil size, the optic zone, what is the higher order aberrations induced, the point spread function, because we might veer to think towards a topo-guided regularization of those topographies if some other issue is there. And again, it is also important to do the epithelial map, which might tell us when you're doing a surface ablation, how much epithelium are you going to remove. Biometry will help you to know whether there has been an elongation of the eye. AIOC will tell us whether the flap thickness is uniform. We'll give you an idea whether you're going to lift the flaps. Again, dry eye status evaluation is mandatory, because if the eye is severely dry, then we would like to treat it before we do an enhancement. So the options are all of these. I'm not going to name them. So when and where? So when would we do flap lift? I would say ideally it should be best done within 3 years as the outer limit, and it's important that we define the flap edge and try to lift the flap in a very smooth manner without disrupting the epithelium, because we do not want to seed in epithelial nests. Again, it is important that the ablation should be safe, absolutely centered. And we should try to avoid lifting thinner flaps, which you can see on AIOC. If there is a buttonholing or a regular flap or a low hinge, we just do not lift those flaps. But if the flap lift for some reason is being considered beyond 3 years, it is important that we debride the epithelium a little beyond the flap margin all around. Again, if the flap is to be recut, if the original flap is decentered, then we would rather, what we could do is, which Kumar has a wonderful video, where he had created a deeper cut of a larger diameter if the corneal thickness would allow. You could do a mini flap over the primary LASIK if the flap thickness is good. But if the plane of cut is different, you could actually end up with flap fragmentation, loss of BCVA, and flap cut should be kept as a last resort. Surface ablations is very safe. You could do a wavefront optimized indicated cases, topo guided indicated cases. It makes sense to incorporate the epithelial thickness and customize your PRK. Mitomycin usage is absolutely mandatory, and you could combine it with low fluence cross-linking in those borderline cases or hyperopic ablations. Again, surface ablation has a wonderful role, post-smile, post-RK, complicated primary LASIK procedures. Always we combine it with MMC. But let's remember, if it was a primary flap was thin and you do an PRK, you could notice those microstriae appearing on the undersurface. And again, the post-op regimen is as similar as surface ablation, placing base-CL, topical steroid drops, adequate lubricants. And in case there's a delayed epithelial healing, you would delay your medical management. When it comes to smile, now what is the thickness of the cap? What is the thickness of the underlying bed? Those are going to be important criteria. And also, does the patient desire to remain flapless is a thing to be considered. When you're doing enhancement post-smile, you could think of doing a PRK. You could think of doing a thin flap LASIK if the initial cap is at least 120, 130 micron. You could do a smile, which is done in a very limited way, anterior to the primary smile or posterior to it. Or you could do a circle software, or if very high residual because of increase in axial length, you do a phakic IOL. There's nothing much to talk about PRK because as I had earlier alluded, it could be either optimized or topo guided. And you definitely need anterior segment OCT inputs are needed. And thin flap LASIK, again, we should remember that it should not impinge on the original interface, and it should be taken that a gas bubble breakthrough does not occur or a buttonhole does not occur. We need to be conscious about that. Secondary smile, I personally have a very limited experience. I was hoping Dr. Sri Ganesh would be there. He has done some secondary smile. The other option is you can convert the smile to a flap. How you can do is you can use a circle software. In circle software, there are 4 ways of doing it. Either you create a lamellar rim and a junction cut and a side cut, and then you can go ahead and do it. I'm going to show you the video. How you go about it is you first create a lamellar ring where in the dimension of a flap cut, and then once a ring is created, then you would lift up the flap. The ways are either you could create a pocket above the ring, above the flap to be created, or below, or on the same level. But the D approach has been found to be the best approach, wherein you create the lamellar ring in the same level as the primary surgical procedure. And then this is the way you would lift the flap. And then you would do the laser ablation as you would routinely do, turn the flap back and do the laser ablation. So basically, when we talk of regressions post-smile, as I said, you could think of doing a thin flap LASIK if the cap is thick. Otherwise, you could do a PRK or convert the cap to a flap with the circle software with the D approach. And phakic IOLs, very rarely it might have been needed if there is a large residual error because of progression of myopia. The complications which are to be anticipated is you could have an epithelial ingrowth. You would have to then strategize your treatment protocols accordingly. You might be prepared for haze post-regression, and you need to use mitomycin and topical steroid drops adequately. You should beware of ectasia. DLK again could be anticipated. Rarely you could have infections, and increased dry eye status should be looked out for. We need to counter it, which could have been the primary cause for the regression. So I would like to conclude stating that yes, modern days regressions are less because we are very, very careful in our selection of cases and we are very critical about it. But it needs to be well investigated, and if so, and if we do it the proper way, regressions can be definitely well managed. Thank you. Any questions for the audience you have before our next speaker could be? Yes. Any questions?
What is your enhancement rate in SMILE compared to LASIK and PRK?
Actually, we are very selective. Like any corneal-based procedures is only less than 9 diopters, and high cylinders we don't do SMILE, we do contoura LASIK. So based on that, we have actually not calculated, but there are very few cases where we have gone and done an enhancement. Compared to what LASIK we used, the regressions we've had earlier. Even in LASIK, our regressions have gone down dramatically because of our very stringent selection criteria. So I think earlier days we were treating higher parts than the corneal thickness would allow. And nowadays, at the drop of the hat, we shift to phakic IOL if the corneal thickness is suspect. Your thoughts on that?
Yeah, so our enhancement rates on SMILE are very, very low as compared to LASIK. Somehow, even with high corrections, we've seen like 7 or 8 or 9 diopters. We are seeing less enhancement rates. Early days when we started doing SMILE, we had a few hyperopic surprises, which now are sorted because they were more to do with the energy and everything, but now we don't. And what about ectasia, like post-SMILE ectasia versus post? Because now you have good numbers.
Yes. Post-SMILE ectasia, it is not, ectasia in general is less, whether we do femtolasic or SMILE or anything, because our way of identifying ectasia has become phenomenal. But having said that, absolutely normal topographies, even in SMILE, we've had those surprises wherein we have not waited exactly. We've just gone ahead and done a cross-linking for these eyes just as we would have done in LASIK. Shresh wants to add something?
No, I mean, I think SMILE ectasia, LASIK ectasia, I don't think there is any difference at this point of time to suggest any alteration in our screening criteria. So when a patient is a contraindication for LASIK, he's a contraindication for SMILE as well. That's the only thing I'd like to add.
Yeah.
What's the cutoff of all of you on the panel on the bed minimum for SMILE?
Minimum for any refractive surgery, we would definitely leave minimum 300 micron.
I mean the cap. Sorry, the question is the cap.
The cap thickness.
Yeah.
The cap thickness, I would keep it as 110, and I have brought it to 100 when I've treated a little high myopic correction, but never 90% is
standard
110.
is 120 microns, and I reduce it up to 100 microns if I want to improve the residual bed. But I like to keep a residual bed of at least 280, preferably 300.
Ganesh, I have a quick question because this is always a dilemma. Would you rather have extra 20 microns on the cap or on the bed?
Right now, I think it's more on the bed.
On the bed.
The cap, because see, Dan Reinstein has published he keeps 135 microns. But the thing is, once you kind of make that incision, it never kind of heals. So I would rather have it on the bed, though the anterior corneal fibers are stronger, but once you have that separation, then I think the strength comes down to some extent. And don't go by mathematical modelings, because we have done in our 10,000 cases of SMILE, we have had ectasias, and of course cross-linking does help, but I mean, ectasia is, see, when we talk about biomechanics, we're just looking at incidence of ectasia, but ectasia is a pathology. So if you have ectasia, whether it's LASIK, SMILE, PRK, you will still progress. If you have keratoconus, early keratoconus, it's going to progress to ectasia. The only reason you want to do cross-linking is for stabilizing the cornea to some extent. If it's kind of borderline, if you're suspect on topography, you don't know the decision, but if it's like abortive keratoconus or form frustrated keratoconus, then probably a phakic IOL will be much better.
Even in patients who have pristine tomography, pristine Corvis, biomechanics, whatever screening tools we have today, there are still patients in the postoperative period, either because of a mild dry eye or whatever be the reasons, who definitely incidence of eye rubbing, the subclinical inflammation starts going up, and that kind of becomes a vicious cycle for onset of ectasia, which whatever screening tool we use may not be able to detect to the
We had a SMILE ectasia last week, 4 years post-op, was 3 years post-op documented on Pentacam, doing extremely well, pristine cornea, nothing. In the last 1 year, she's somehow developed allergy. She's been rubbing her eyes and, got went into ectasia.
I think important that we tell all our patients who get LASIK done never to rub their eyes, and I tell that routinely to all my patients.